Hello, now we are with Jamie, a big professor that's a friend of mine. He was talking about the small renal mass, how to manage it. And I'd like to ask you the highlights of your presentation in plenary. What do you think about small renal mass? If you can manage more active surveillance, more biopsy, what do you think about that?
So thank you for the opportunity. It's really a tremendous pleasure. We had a great little session. The theme was a 3-centimeter renal mass to be specific, and it was run by Dr. Lalas. Doctors Lane and Ponsky joined me. I represented active surveillance just to summarize, but essentially we all just ran through everything. I would distill this down to the small renal mass remaining a massive problem in that we are mismanaging it in an enormous way. I hate to say that, but I think our guidelines are misguided. This is going to sound very controversial, but renal mass is the only mass among all the organs, among all the surgeons, that does not have a biopsy-based standard. Because of that, what we're doing is mismanaging a tremendous number of patients. In the U.S., recent studies showed that up to 30% of patients that have partial nephrectomy never needed it. They had benign disease. So when you talk about a treatment strategy that kept coming up in our session as a gold standard, partial nephrectomy is a gold standard, you can't say your hammer is good for every job in the house.
Yes.
It's just wrong. We have multiple tools. You got to take the patient, their specific disease, and tailor a strategy that's right for that patient.
Perfect.
We all do that for everything else, and it's time we woke up and did it for the renal mass.
Yeah, that's perfect. You have to individualize the patients and treat each patient as one patient.
Exactly. Yes. Personalized medicine is something we all talk about, and yet when it comes to renal mass, we name a procedure as a gold standard, when in fact we first need to define the disease. We have to understand that disease in the context of the patient, and then we can make some intelligent decisions as to active surveillance, ablation, or extirpation.
Perfect. And for all active surveillance patients, do you perform biopsy?
Not for all. So there are many patients who are deciding between active surveillance and some type of true intervention, be that ablative or extirpative, and if they want to make that decision-making process, they should have a biopsy. If somebody's a bit older, does not have a long life expectancy, has a relatively small tumor, and they're very comfortable with active surveillance, they don't need a biopsy. But I will say that anyone who I'm considering some form of intervention, they pretty much have to have a biopsy. It makes no sense to treat them without it.
So thank you so much.
Truly a
Congratulations.
great pleasure. Thank you.